Are you currently trapped in a cycle of temporary relief and agonizing relapse? Do you spend hours lying flat on your back with an ice pack, terrified to move because you know the severe muscle spasms will return? Have you been swallowing heavy doses of muscle relaxants and anti-inflammatory pills for more than 6 months, only to find that your baseline back pain is actually getting worse? Finally, has a local doctor looked at your MRI and casually told you that your only remaining option is to permanently fuse your spine together with heavy titanium screws? If you are experiencing these situations, your frustration and fear are completely justified. You are caught in a treatment illusion. You are attempting to fix a mechanical collapse using temporary chemical solutions. Today, we are going to look at the hard medical data, explain why prolonged rest is destroying your spinal support system, and break down the exact surgical and non-surgical protocols required to permanently stabilize degenerative disc disease. To effectively treat a dying spinal disc, you must completely change how you view pain management. In spinal medicine, treatments fall into 2 strict categories: passive treatments and active treatments. Passive treatments are procedures done to you. This includes swallowing a painkiller, receiving a massage, applying a heating pad, or using an electrical stimulation machine on your muscles. Passive treatments do absolutely nothing to alter the underlying mechanics of your spine. They do not rebuild lost cartilage, and they do not restore the height of a collapsed spinal disc. They exist solely to temporarily lower the volume of the pain alarm in your brain. Active treatments are actions you perform with your own body. This includes targeted muscle strengthening, specific flexibility protocols, and precise ergonomic corrections. A dying disc causes abnormal micromotions in the spine. Because the disc is deflated, the spinal bones wobble. To stop the wobbling, you must build a thick, powerful corset of muscles around the spine to act as a permanent external physical cast. Passive treatments are only useful if they provide you with enough temporary pain relief to get off the couch and engage in active mechanical rehabilitation. The muscles are your primary defense against gravity. If your muscles are weak, the entire weight of your torso crashes directly down onto the failing disc. This brings us to the most destructive habit in chronic back pain management: prolonged bed rest. When a degenerated disc flares up and causes agonizing muscle spasms, resting in bed for 1 or 2 days is medically appropriate to let the acute inflammation settle. However, resting for weeks is a catastrophe for your anatomy. Your spinal discs have no direct blood supply. They require physical motion to pump nutrients, water, and oxygen into their tissue. If you lie completely still, you are physically starving the remaining healthy tissue inside the disc. Furthermore, human muscle tissue wastes away incredibly fast when it is not bearing weight. Prolonged bed rest melts away the deep stabilizing muscles of your core and lower back. When you finally stand up, the muscular support system is completely gone, triggering an even worse pain flare-up. This is exactly when patients reach for daily anti-inflammatory pills or narcotic pain medications. These drugs suppress the chemical signals of inflammation, but they do not stop the mechanical grinding. Relying on daily medication forces your kidneys, liver, and stomach lining to process highly toxic compounds for years. You are risking severe stomach ulcers and organ damage to mask a mechanical joint problem. You must move to heal. We recommend low-impact aerobic exercises like walking in a swimming pool, where the water supports the weight of your body while allowing your spine to move, pump nutrients, and restore blood flow. Before we can prescribe a precise physical therapy routine or consider surgery, we must objectively map the exact nature of your spinal failure. We do not guess based on where your back hurts. We require high-definition magnetic resonance imaging, or MRI. When a neurosurgeon reviews your MRI, we are evaluating 3 distinct factors. First, we look at the disc height. A severely degenerated disc will collapse, shrinking the distance between the 2 vertebral bones. Second, we look for modic changes. These are highly specific inflammatory signals inside the bone itself, indicating that the protective cartilage end plates have eroded and the bones are experiencing severe structural stress. Third, we evaluate the neuroforamen, the small bony tunnels where your nerve roots exit the spine. When the disc space collapses, these tunnels naturally become narrower. If the disc is also bulging outward, it can completely crush the exiting nerve root. We must map the exact millimeter of failure. A patient with isolated back pain requires a completely different treatment protocol than a patient whose degenerated disc is actively crushing a nerve and causing severe leg weakness. If you cannot exercise because the nerve pain is too severe, we must use highly targeted medical interventions to break the pain cycle. If the proteins inside the dying disc are leaking out and chemically burning the surrounding nerve roots, we must put out the chemical fire directly at the source. We accomplish this using epidural steroid injections. Using live X-ray guidance, a specialist guides a thin needle directly into the epidural space surrounding the inflamed spinal segment. We deposit a concentrated dose of powerful anti-inflammatory medication exactly where the disc is failing. It rapidly shrinks the swollen tissues and stops the nerve from transmitting the burning sensation. An epidural injection is not a permanent structural cure, but it provides a critical window of profound pain relief, often lasting several months. This window allows you to aggressively pursue physical therapy and muscular stabilization without agony. If you have endured 6 to 12 months of aggressive physical therapy and targeted injections, but the pain remains entirely disabling, or if the collapsed disc is causing severe progressive neurological weakness in your legs, we must evaluate structural surgery. The goal of surgery is to definitively alter the underlying mechanics of the spine. We escalate our treatments based entirely on your unique anatomy. If the disc is bulging but the height is relatively maintained, we use ultra-minimally invasive techniques like percutaneous laser disc decompression. Under local anesthesia, we guide a microscopic laser fiber into the center of the disc to vaporize the internal pressure and shrink the bulge without making a single surgical incision. We preserve your natural anatomy at all costs. However, if the disc space has completely collapsed and bone-on-bone grinding is destroying the vertebrae, we have 2 primary options for major reconstruction: spinal fusion and artificial disc replacement. For decades, the gold standard has been spinal fusion. The surgeon removes the dying disc, inserts a spacer cage filled with bone graft material, and locks the 2 adjacent vertebrae together using titanium rods and screws. By eliminating all movement at that joint, we permanently eliminate the grinding pain. However, fusion forces the healthy spinal discs directly above and below the fused block to take on double the mechanical stress, which can cause them to wear out faster in the future. To solve this mechanical problem, biomedical engineering created artificial disc replacement. In this advanced procedure, we remove the dead disc, but we do not use metal screws to lock the bones together. Instead, we insert a high-tech implant made of surgical-grade metal and a medical plastic core. This device acts exactly like a natural shock absorber. It preserves the natural bending and rotational motion of your spine. By preserving motion, an artificial disc dramatically reduces the stress placed on the rest of your spine, protecting your healthy discs from future collapse. Spinal surgery is always elective, and it is a permanent, life-altering decision. You should never agree to a spinal fusion simply because a local doctor has run out of ideas or pain pills. You must demand to know if you are a candidate for motion preservation, laser decompression, or advanced active rehabilitation. Every spine is unique, and applying a one-size-fits-all treatment is dangerous. Stop guessing about your surgical options. Let our expert neurosurgeons review your complete medical history and imaging. Click the link in the description to upload your MRI or CT scans to our secure portal. We will map the exact stage of your disc degeneration, provide a definitive, personalized second opinion on your surgical or non-surgical options, and help you take control of your recovery.